Yeah,
So
you
I'll
can
just
start off the session. We are live now.
perfect. Thank you, Dr. Nikhil, and thank you, Dr. Rahul Banerjee. I think Rahul is a very common name in the country. Popular can also be sorted later down the line. But yeah, it seems to be a popular name. So thanks, Rahul, for joining in today in this uh, excellently conducted series in innovation in hematology. From people from different walks of hematology come together once a month and enrich with their own experiences. People across 40 countries, 500 plus people do join on these webinars, and they have a take home message for their own countrymen how to do that, not only in India, but across Bangladesh, Iraq, Kenya, Nigeria, and today people from Vietnam and Myanmar have also joined in. So it's an exciting platform which has been provided on Zoom, where we can cut across the chase and we can discuss the real science in next 35, 40 minutes. The pattern has been created by us at Fortis Institute of Blood Disorder, where 15 people work together and we are trying to develop one doctor, one disease concept, which has been lacking in the country. But soon we are going to reach on to that. We have a huge genetic space at this time in Fortis. We get our NGS in 3 days, and Dr. Nikhil right now is heading the sphere for us in myeloma and amyloidosis and lymphoma. With this, I would hand over to Dr. Nikhil. We are all excited. Everybody is excited to listen to you because they have been living longer thanks to these wonderful drugs. 8 year, 10-year plus myeloma transplants, 91% survival at 5 years with our own data. I think it's an exciting space, and we would like to hear from you how to manage these toxicities from this miraculous drug, which are very, very different from what we have heard and what we have seen. So, with this, Dr. Nikhil, over to you, and Rahul, welcome to this platform from Fortis Institute of Blood Disorder. Over to Dr. Nikhil.
Thank you, Dr. Bhargav. So, in 2024, multiple myeloma has become more like a chronic disease, with patients having access to a wide range of therapies and the overall survival ranging from 8 to 10 years for a standard risk and 7 to 6 years for a high risk myeloma. But patients on treatment for a prolonged period of time, drug toxicity becomes a major concern, and this is one of the major deterrents affecting the quality of life of myeloma patient. And very often, it is not given due importance even in patient discussions and also in scientific discussions at various forums. So we at Fortis Institute of Blood Disorders thought this is something which has to be discussed in great detail because very often it requires many practical strategies and clinical insights to manage these patients better while mitigating drug toxicity. And Dr. Rahul Banerjee is a well known name in his space. He is an assistant professor at the Fred Hutch Division of Hematology and Oncology, University of Washington. He has done extensive work in the field of drug toxicity, and many of his research work, the latest one being the Downward Dex paper, which was quite good and discussed widely across different forums. He has done remarkable work in the field of multiple myeloma, and his areas of interest includes managing drug toxicity and developing strategies so that patients can tolerate their treatment better. He requires no introduction. He is a renowned hemato-oncologist from the prestigious Fred Hutch Cancer Center and a leading expert in the field of multiple myeloma. He has extensive experience in myeloma treatment and research, and this has earned him a recognition as a thought leader in this space. He is a member of the International Myeloma Working Group and has published more than 70 peer reviewed publications with an emphasis on patient experiences as they undergo multiple myeloma treatment. Dr. Banerjee has developed a unique perspective, and his research has thrown a lot of emphasis not only on treating the patients and achieving good responses, but also on managing myeloma related drug toxicity. Today, his presentation will offer valuable insights and practical strategies for health professionals as well as patients navigating this complex aspect of myeloma treatment, where Dr. Banerjee will share his expertise on managing myeloma related drug toxicity and also provide us valuable insights from his clinical experience. The audience, as well as the delegates who have joined in, please feel free to post your questions in the chat box so that we can have a very nice discussion at the end of his talk. Before I hand over the session to Dr. Banerjee, I would also like to introduce the speaker for our next webinar in December, where Dr. Nitin Jain from the MD Anderson Cancer Center would be speaking to us on time-limited treatment strategies in CLL on the 20th of December from 7 p.m. to 8 p.m. Indian Standard Time. So this is our team of doctors at the Fortis Institute of Blood Disorders, where we do more than 200 to 250 transplants, and we have a dedicated myeloma and lymphoma unit and a lot of trials in this space. So without taking up much time, I hand over the session to Dr. Banerjee. I'll stop sharing my screen.
Wonderful. Thank you, Dr. Nikhil, for those very, very kind words, and Dr. Rahul for this, Dr. Bhargava, for the very kind introduction and inviting me to be here. It's a pleasure to be here. It's telling everyone it's I mean, either Desi physicians or the project of Desi physicians have done so much for everything around the world, I think. But honestly, like the original, all of our physicians in India, all of you working with your innovations in bortezomib dosing and carfilzomib from the real world data, a lot of the coolest stuff in myeloma, I think, is happening in India and in this entire Indian subcontinent. So I'm excited to see. Let me share my screen here. And let's try presenting. And let's see how that looks.
Perfect. It's visible
Perfect.
and audible.
Wonderful. And so what I thought I would do is, and Dr. Nick, thank you all of you who posed questions in advance, and Dr. Kumar, Dr. Nikhil kind of put them together nicely for me. So I think these slides should only last about 30 minutes altogether at the most. I'd love to spend most of the time talking about the nuts and bolts of managing toxicity with all of you. I think it'd be good as a more of a dialogue back and forth. There's not much evidence for many of these. So the first 30 minutes, I'm focusing on the evidence that does exist for actually toxicity management in myeloma, particularly in the frontline setting, how we do it, why we do it, and what the results are. And so we'll do that. And then the nuts and bolts of how do we actually manage patients with drug holds and side effects and so forth, we will definitely spend a lot of time on thereafter. So my main theme for these next 30 minutes will be less is more. So a lot of focusing here, not so much on different drugs to manage the side effects, but how do we actually optimize the dosing of the drug that we already have for our patients. Here are my disclosures. And so let me put this up here. So I think there's kind of, again, three things we'll talk about: proteasome inhibitors, dexamethasone. Very briefly, I'll touch on other drugs, but again, I would love to hear from all of you because, what works for me, for my patients in the United States, may be different from what works in India in terms of what medications are available, side effects, etc. So I'm actually most excited for the discussion hereafter. So first, proteasome inhibitors. So very briefly, in terms of the history of bortezomib, some of you have lived this for longer than I haven't seen these drugs. 2002 was a very first study here of PS341, which ended up becoming bortezomib. The rationale at that point, the stated rationale I've heard there is that, twice weekly dosing was because proteasome activity returns to normal 72 hours after each dose. And so that's why they said, let's wait 72 hours and dose the next one. That is the official story. The unofficial story I've heard is Paul Richardson, one of the doctors in Boston. Apparently that was his clinic schedule, Mondays and Thursdays and Mondays and Thursdays. And so that's what they rolled with. Who knows? Probably some mix of both of them, but that's how the first the study of this started. And then it kind of went from there. So in 2003, there were several phase 2 studies, the Summit, Crest, and Apex studies, all used bortezomib. We'll talk about the dosing, but typically at 1 or 1.3 mg per meter squared, all weight-based dosing twice weekly intravenously. Many of you are familiar with the SWOG SO777 study. So that was a large phase 3 study in patients for whom transplant was not planned. VRD with bortezomib lenalidomide index was compared to RD lenalidomide index, and VRD outperformed RD. So bortezomib here was dosed, again, 1.3 mg per meter squared IV twice weekly. And then there was a phase 3 study in 2011 that showed that subcutaneous bortezomib was non-inferior to IV bortezomib. And we'll talk about this because it's very relevant to, I think, the patients in India. Any grade rates of neuropathy were lower, as were rates of grade 3 plus neuropathy. And so, just to talk about the lore of myeloma, right, how things are often not evidence-based until suddenly they are evidence-based. Why did sub-Q bortezomib first originate, right? How was this drug able to go from IV to subcutaneous dosing? If you talk to Dr. Mateos, she from Spain, she had this article where she wrote about the history of bortezomib, and she said that it was monkey research and cynomolgus monkeys that led to us discovering very carefully that subcutaneous dosing was okay, and we replaced IV with subcutaneous. If you talk to my old boss, Tom Martin, on this coast of the United States out in California, he says it's due to a medical error in France where a nurse accidentally gave a patient subcutaneous bortezomib. Patient did totally fine, and then that hospital started doing it again and again and again. And so I joke to in all these talks I give, which is it? Is it the monkeys or is it the French who kind of, led to this great serendipitous invention that led to bortezomib being dosed subcutaneously? And it's in French, vraiment un peu des deux. It's a little bit of both, right? And a lot of this, the little science that goes into it, but honestly, it's just a lot of luck or someone really trying to think outside the box, saying, look, why are we doing it that way? Let's try changing it and showing that it works, and oftentimes works better. So the question for me is, can that serendipity extend elsewhere, right? So we know, for example, that subcutaneous beats IV, equivalent outcomes, better safety. What about once per week instead of twice per week? So some of you may know this is one of my big kind of first pushes in this field to just fix it. I probably many of you are using once per week bortezomib, to be clear, and I don't doubt that at all. So, why? Less time in clinic. We do it for our older patients, at least in the US for VRD light. The question is, can we do it for our younger patients as well? And the balance that you're trying to strike here is, on the one hand, you have this idea of time toxicity, right? Patients are coming in twice per week instead of once per week. That's a lot for them, and any country does a lot. The risk of neuropathy is undoubtedly higher with twice weekly bortezomib versus once. But on the other hand, you have these data, preclinical data, pharmacodynamic data showing that the proteasome inhibition lasts for 72 hours. So you try to figure out, well, what's more important, right? Is it what makes more sense for the patient or what makes more sense on these old experiments? So there are two big studies that we published last year looking at this. So this first one is looking at almost 2,500 US patients. I'm sure data will be very similar for Indian patients as well. Treated frontline bortezomib here. We published this last year in Blood Cancer Journal. Vincent Rajkumar is the big editor. He was a senior author of this paper. And you saw equivalent PFS, progression-free survival between twice weekly and once weekly. Even if you were to take these at their verbatim amount and not attribute for the confidence intervals being completely overlappable, this ends up being like a 2-month-ish benefit by medians, but many, many more days in clinic. So I think it completely washes out. And here, at least, the rate of neuropathy with twice weekly bortezomib was twice as high as that of once weekly bortezomib. The question some of you may be asking is, well, don't we already know this, right? Like, well, obviously everyone knows that once weekly bortezomib is the norm. Yes, but also no, right? The challenging part is that, we've kind of known this for decades. As early as 2009, there was an Apex analysis from one of those first phase 2 studies of bortezomib showing that you can have less neuropathy, equivalent PS with dose reductions. The Alcyon study largely enrolled, in Europe, my recollection is from 2015 to 2016. They used once weekly bortezomib after the first cycle of those in transplant ineligible patients. I know that there were some sites in India that participated in the Boston study. That was a study of selinexor Xpovio, which is a new agent. We can talk about it, not as much efficacy, I would argue. They actually capitalized on this. So this was a phase 3 study where they did Celi VD versus VD with bortezomib. And then in this arm, the VD arm, they got twice weekly bortezomib, but in the Celi arm, they got once weekly bortezomib. And Celi VD outperformed VD and also less neuropathy, unsurprisingly, because there was less bortezomib involved. However, if you look at the Perseus study, the Griffin study, the Cartitude-6 study, that's the study of CAR T versus transplant frontline in myeloma, all still using twice weekly bortezomib. And so the question is why? So why then, in despite of 20 years of evidence, are we still doing twice weekly bortezomib in clinical trials? And it's hard because, as many of you know, some of these novel agents, like the only way they're available in countries like India is through clinical trials, and you're asking patients to do something that you wouldn't have them do otherwise. And so why not do less is more, right? So, this is one argument that used to be made 20 years ago that, well, who cares about clinical data from 2,000 patients? Let's talk about proteasome analysis in the 2000s. I don't think anyone believes that anymore. There are those of you who are on Twitter or X will know that there are some people out there who are very big proponents of this, that everything in life needs a randomized controlled trial. You'll never, ever know anything unless you do a randomized controlled trial. I don't think that's true. That's not practical. In all honesty, a randomized trial of twice weekly versus once weekly bortezomib today, I think would be unethical because we already know the answer. And then this is the real issue. And I'd be curious to hear all of your thoughts how this applies to Indian regulatory authorities in terms of drug approval. But what tends to happen is, as you can imagine, these drug companies are investing so many lakhs worth of money into a study like this, and they want to make sure that it gets approved. And what happens is, they're worried that the regulatory agencies will say, oh, well, you didn't use twice weekly bortezomib the way that SWOG SO777 did 15 years ago, and so your control arm was inferior to the standard of care. I could argue that that's not the standard of care. The standard of care is once weekly bortezomib, but it becomes a cycle that because no new trial is willing to use once weekly bortezomib, the old trials don't use it, and the new trials become the old trials that don't use it, and turns this vicious cycle. So myself, again, a lot of Desi, either expats or second generation Indians, Dr. Gurbakhsh Kaur from UT Southwestern and Mount Sinai, and then Vincent Rajkumar, whom I'm sure many of you have met or know about at the Mayo Clinic, are really working on fixing this. So there's another piece that we published in Blood Cancer Journal last year. Nikita Mehra, some of you may know from Adyar Cancer Institute in Chennai, was one of the authors of this. Some of you have done the survey, and if you did, thank you. This was a survey of 217 physicians in 38 countries. 29% of them were from LMICs, low and middle income countries. And we asked them, how do you dose bortezomib? What would you consider to be the standard of care? And overwhelmingly, right, once weekly bortezomib was used by 95% of patients for their own patients, is what people reported. Here across the board, you can see here, majorities of respondents said, look, the once weekly bortezomib has equivalent durations of response, less neuropathy, preferred by patients, and so forth. Again, at the very bottom here, I'll add, because this probably will come up, if someone is having acute calf nephropathy or some sort of emergent complication, twice weekly is totally reasonable, but for everybody else, it really should be once weekly. The point here is that we tried to make it very clear, and we're working with the FDA, International Myeloma Society, to help propagate this, to make it clear that no clinical trial should ever run afraid of this. Like they should always say once weekly bortezomib is what doctors do. It is the right thing to do. Therefore, it's what we'll do in our clinical trials as well. So to summarize here, two papers that I was a big part of. So one, real world data shows once weekly bortezomib works just fine for patients. Two, as I alluded to, there would it not be fair. I won't name names, but it's actually also it's second generation Indian Americans here in the U.S. who are some of the big proponents of everything needs a randomized trial. There would be no equipoise. I'm sure many of you would agree. I would not feel comfortable putting my patient on a trial of once weekly versus twice weekly bortezomib today, since I already know the answer. And then we made this very clear in our paper, and we're hopeful. And at least a couple of drug companies that looked to us and said, "Look, we're going to use your paper to see what happens." I was like, "Great, use it and let's fix this." So, the FDA says the standard of, in the US at least, says the standard of care is publication in a peer-reviewed journal. Peer-reviewed journal. This is time to roll, and we'll see what happens. So we're meeting with them, Dr. Munshi and Dr. Kumar, also all Indian Americans or Indians. We're working with them to plan the next FDA symposium. If we can get the FDA to bend in the United States, hopefully other sponsors will kind of say the same thing as well. In the interest of time, I won't spend too much time on this. We're doing something same with carfilzomib. This is in the Review of Blood Cancer Journal, where you can see basically, and this is a question I'm sure will come up, how do I dose carfilzomib? I tend to do it 56 per meter squared once weekly after the first dose. Twice weekly really has no benefit, at least in this large analysis here of over 500 patients. 70 once weekly, I just have found that patients do not tolerate, not even in terms of cardiac risk, but carfilzomib, for me, a lot of my patients have infusion reactions or nausea afterwards, and you can give them dexamethasone, but I'd rather just lower the dose of carfilzomib. Thankfully, in the US, this is kind of happening with time anyways. On this axis here, this is how many patients are using twice weekly 27 mg per meter squared. The orange is coming down with time. And then the green here, which is 56 once weekly, going up with time. Again, I'll skip over this in the interest of time, but we can come back to it. Very briefly, this is a challenge in India. Again, I would love to hear from all of you about how you are navigating this, because I've heard about this. Obviously, I haven't actually practiced it, where you have all these different vendors that are producing bortezomib, and many of them, as you know, says like for IV use only, for IV use only, for IV use only. Not much. I was just Googling and I found maybe this one says for IV/sub-Q use only. So whatever this vendor is doing, I would love for all the other ones to do. But this is a problem I know, and I've heard it, that it's a problem in many countries where the vial packaging has not been updated. And so you're putting your nurse in a weird situation when you're saying dose it subcutaneously, no reformulation required, just use it. But the vial says IV. One interesting thing is we'll talk about here, and this is an example where actually research from India has really helped. India and Mexico, I think, are the two countries that have helped with this. You can see here some of these. There's a 2 mg vial, 2 mg vial, 2 mg vial. That one 3.5, 2.5 mg vials. In the US, all of our vials are 3.5 mg. And so why does that matter? I'm very happy to see 2.5 milligram vials because, as all of you know, 3.5 milligram vials are ludicrous. At least if you go at 1.3 mg per meter squared dosing, and if you assume that most people are, maybe like 1.5 to 2 BSA as their BSA in a meter squared, you end up with a dose of 2.6 to 3 milligrams being used, and you waste the rest of the vial. And so on the right here, just an example, I was senior author on this analysis that got published earlier this year, at least in the United States. Bortezomib is the top most wasted drug in America. That sounds, oh, sorry, the top most wasted oncology drug in America. It's a very dubious badge to have. At first, they were like, oh, wow, myeloma, it's like not that common of a cancer compared to all the breast cancer, lung cancers out there. But again, over a quarter of each vial in the US is being discarded on average, being reported back to Medicare, which is our government healthcare authority. So that's a problem. And you can see here basically that, 1.0 mg per meter squared, this is data from Rakesh Bopat and others years ago, showing that 1.0 mg per meter squared is totally fine for patients. And so practically speaking, if you do have a 3.5 milligram vial in Mexico, I didn't put this here, there have been data, and there have been data from an Indian group as well, looking at splitting vials, sharing vials, like planning which days you're giving bortezomib, splitting the vial in half dosing it, generally, it will absolutely lower healthcare costs, and at least in terms of 1.0 mg per meter squared, will lower the neuropathy risk as well, which is great to see. Okay, so let me move on here, and then I'll talk about Dex, other drugs, and I'll leave time for discussion. So dexamethasone. So many of you are very familiar with this medication. So I give this slide somewhat tongue-in-cheek to show the progress that we either made or haven't made. So this is just a comparison of two very large phase 3 studies. I would argue the biggest phase 3 studies that led to the build of, what we often use, at least in the US today, DARA-VRD, as our induction regimen for newly diagnosed myeloma in patients who might be able to undergo transplant. And you can see here that if you kind of compare over time from 2008 to 2012 to 2020, the SWOG SO777 studies and the Perseus studies, here, everything else makes sense, right? Lenalidomide is pretty stable, bortezomib pretty stable, albeit twice weekly, as we've talked about. The DARA was added on only to one arm here. The dexamethasone was 14% of all days people were getting dex, then 19%, and then actually 29%. The Perseus study used dex pulses. And so the analogy that I might give for this is kind of like this, right? You had a totally fine plan here, like a very nice Day of Death movie, and then you go and add all these, tamaka, all this fancy stuff thereafter, and like, is it actually adding anything to the premise of what you're trying to do? Who knows? When was dexamethasone first developed is actually almost as old as me. I am older than this, I promise, but not by too many years. So this is data from over, 35 years ago showing that dexamethasone by itself, actually at that point it was dosed in milligrams per meter squared, did show some responses as monotherapy. Interestingly, dexamethasone almost didn't make it as a myeloma drug. So the IFM 9501 study that was published in 2006 looked at dexamethasone in older patients. Again, in Europe, older means 65 and up. So I would say this is actually the typical age, at least in the US, probably maybe older by Indian standards. I'd be interested to hear about that. They looked at either dexamethasone or these dose regimens here with either dex alone or plus melphalan or plus interferon alpha. They dosed dex in pulses, right? 4 days on, 4 days off, 4 days on, 4 days off. And they actually found higher mortality in the dex arms versus the MP, the melphalan prednisone arm. And the trial was actually closed early with a DSMB. And the paper in Blood, they actually said they would not recommend dexamethasone for elderly patients, again, over 65 for exactly this reason. So I think we knew even then that dexamethasone 40 milligram pulses were probably not the way to go. This, many of you are familiar with, is one of Dr. Rajkumar's probably, I would argue, most seminal papers. So this was a study looking at dexamethasone as part of RD, so lenalidomide dex doublet induction in one of two doses, either dex pulses or dex 40 milligrams weekly. Patients were very involved with this, which I think is really good to see. The patients were the ones pushing for the study to happen. You saw here that there was an improvement in overall response rates if you gave, patients who achieved the partial response or better with the high doses of dex. However, 1 year survival was a full 9 percentage points lower, 87% to 96%, and the study was stopped early by the DSMB. On the right here in the Lancet paper, this is the overall survival. Low dose dex is top green, high dose dex is this blue here. You can see it's dropping off pretty significantly. Despite the over response rate, the deaths from progressive disease are about the same, but all the AEs, the adverse events, started to pick up here with the pulse dose dex, particularly blood clots and cardiac issues. So, with that study, we figured out for sure that 40 milligrams weekly is the floor, right? We know that 40 milligrams pulses should not be used. Unfortunately, the Percy study still used it, and I'm very unhappy about that. But it really should be 40 milligrams weekly is better than pulses. The question is, can we go lower than 40? Should we go lower than 40? We don't really know. So there are some data that Dex 40 once weekly does add some benefit, typically to monotherapy. There's a study here on the left here comparing Dex, Palm Dex to Palm alone. This is older data over 10 years ago. And you see that, yes, there is a slight benefit to Palm Dex to black line over the gray line, but the median PFS here is like 5 months versus 3 months, right? This is not an adequate regimen. Same applies for Dex. Isatuximab is a doublet. Again, in real life, I'd probably recommend triplets if I can. So maybe that's the efficacy arm here. Other things, so this is work in terms of sleep. So this was done by Dr. Hebroni, by Dr. Korde, Neha Korde, also Indian. She's the senior author at Sloan Kettering in New York. She and her team actually gave patients wearable device monitors to track their sleep. And so you can see here basically the orange days are the Dex days in terms of sleep over 24-hour period, including naps. The green are the other 6 days of the week. And basically, for most patients here, you can see a dramatic difference. Like this poor patient over here, towards the right here, where the Dex days, the sleep is terrible in terms of minutes per sleep over 24 hours compared to the non-Dex days. All of you know that, but again, just to be clear, even for patients who don't say that the Dex is causing them insomnia, those patients are still also not sleeping properly at night, whether they know it or not. This is work that I've led that got published in the American Journal of Hematology last year, or I guess this year as well, looking basically here that larger, higher lifetime dose of dexamethasone. So if you look here, this is like 9,000 milligrams, 12,000 milligrams, because it's that much dex over the course of years. You see a much higher, I mean, not much higher, but you see a very clear trend here. This is a very positive curve toward a correlation towards more severity of cataracts, not just asymptomatic cataracts that an ophthalmologist picks up. That's a scale 1, but 2, 3, 4, and 5 on this, where patients were not able to drive, not able to function, had to stop treatment, had to get surgery, etc. So there's no doubt in my mind that dexamethasone does cause problems. Can we drop the DEX after 9 months? Some of you may be familiar with this study. This was a phase 3 study published in Blood a couple of years ago by Dr. Alejandra Larroca and colleagues. So it's a study of doublet maintenance. So again, RD, lenalidomide DEX, just like the ECOG study Dr. Rajkumar led, looking at len 25 milligrams, 21 to 28 days versus DEX. And the patients were randomized after 9 months to either continue the same dose RD or to drop the lenalidomide down to 10 milligrams and the DEX down to 0, basically. And they had a kind of their primary endpoint. This was protocol specified with not just PFS, it was PFS, but also len discontinuation or any high-grade adverse events AEs. So a couple of things happened. So in terms of their primary endpoint, event-free survival, they did see a significant improvement with the reduction of lenalidomide and the dropping of DEX after 9 months. PFS was pretty comparable, 20.2 months versus 18.3 months. So again, the main events that triggered were toxicities and having to hold lenalidomide because of toxicity or hold both drugs because of toxicities. This, I think, is very telling, right? So the arm that got the dose reductions had a higher cumulative dose of lenalidomide. If you assume that lenalidomide is a useful myeloma drug, which I do assume that it is, then this is really telling that basically what all the DEX is doing is the DEX is messing with your patients, that it's a high dose and it's causing problems, and you're having to hold both doses, side effects, polypharmacy, they forget the lenalidomide, and all this stuff happens. But here, if you just stop the DEX after 9 months, patients actually end up on treatment for longer and they end up taking more lenalidomide, despite the fact you may remember that in that arm, they actually dropped the lenalidomide from 25 milligrams to 10 milligrams after 9 months. Despite that, you end up with a higher cumulative dose. And here, we don't talk about this that much, but if you look at the actual curves here, the p-value for overall survival is 0.06, favoring RD to R, favoring dropping the DEX after 9 months to put a continuous RD. If it had been 0.04, I'm sure this would have been a huge, like, oh my God, look, like, dropping the DEX makes people live longer. Very close. I would say if they'd enrolled another 20 patients, they would have been there. But it's just something to make a point here, right? That once again, we're seeing that lower DEX is trending towards a better overall survival. So we said, and this was the group that Dr. Nikhil Kumar very kindly alluded to, is a paper in Blood that I'm about to mention that got published just last month, which was a really big deal for me. So I'm happy to see it there. So we looked then at what about more fit patients, and what if the dexamethasone was dropped during induction, not randomized, but just during induction. So we looked at the SO777 study that I keep talking about here. That was a study of VRD versus RD. We also looked at S1211, another SWOG study. Dr. Usmani, Saad Usmani at Sloan Kettering was the first author on that one. So that is ELO VRD with elotuzumab versus VRD in high-risk myeloma, newly diagnosed, was not shown to have a PFS benefit. You can see here how dexamethasone was dosed here, 40 milligrams once weekly or 20 milligrams kind of scattered like this twice per week. In both trials, dexamethasone doses were discouraged. So you can see here, for example, these were the allowable protocol modifications to dexamethasone. If they had high-grade GI bleeding or diabetes, you would stop it. But apart from that, you would lower it, and that was it. And so what we did was, again, this was published in Blood just 2 months ago. We looked at patients in both arms. We pooled them across both arms of both studies, and we pooled them to either FD dex, full dose dexamethasone, who maintained the full dose, versus LD dex. So for any reason, but it would have to have been a grade 3 toxicity, as you saw, lower to dexamethasone. The two groups are actually quite balanced in terms of age, performance status, stage, M spike, even C-reactive protein. However, fewer than a third of patients were able to maintain full dose dex even in these clinical trials. That's very telling. So if dexamethasone was a brand new agent being studied investigationally, and the maximum tolerated dose, or even the recommended dose, 69% of patients were not able to tolerate even during induction, there is no way that that dose would have been allowed to go forward, right? You would have had to have lowered it because only 31% of patients were able to maintain that full dose of dexamethasone. And here, again, this was published here, unsurprisingly, maybe surprisingly, no difference in PFS or OS between these two groups, between low dose dex and full dose dex in terms of PFS or OS on either side here. Technically, it might look like the full dose dex has a slightly higher overall survival, not remotely statistically significant. I will say that probably patients who can handle full dose dex probably are more fit in some ways, but importantly, to my perspective, in terms of PFS here, 34 or 37 months, that I would say that's entirely interchangeable. No difference in my mind between PFS. We ran multivariate analyses to look at predictors of PFS and OS, and full dose dex did not predict that. We went back and did a subgroup analysis, even if you exclude the doublet patients and only look at patients who got at least VRD, so at least bortezomib, lenalidomide, and dex, plus or minus elotuzumab, also in them. The dexamethasone is adding nothing. I should add, I'm gonna have to update these slides actually. At next month's meeting at ASH, there's going to be a French study, IFM 2017-03, similar principle. And I was randomized to either get Dara Rev Dex, but drop the Dex after 2 months, or Rev Dex. And again, Dara Rev Dex optional, dropping the Dex is outperformed Rev Dex. So again, we're seeing the dexamethasone is entirely dispensable here after a couple of months. So what's next? This is an example of study that we're enrolling here at Fred Hutch. This is a phase 2 study that will start. Hopefully more will come of it. We're looking at ESA-KRD. So isatuximab, another version of daratumumab, carfilzomib, all of you are well familiar with, has been studied in the frontline setting, and it is possible to use in the frontline setting, at least in the US. What's important here is a couple things. One, here you see the dexamethasone is 20 milligrams at cycle 1, not 40, regardless of transplant eligibility, and then it's omitted unless you need to. This is the key point here, right? I'm not saying that dexamethasone should be abolished from our armamentarium. Some patients need it for bone pain. They need it for infusion reactions. They need it for nausea. I'm just saying down with dex, right? Lower the dexamethasone dose to a more reasonable regimen here. So here, for example, you can go down to less than 12 milligrams daily, no questions asked. I would still call that down with dex significantly compared to the 40 milligram days of yore. Here, carfilzomib is 56 milligrams once per week again. One little thing here, some of you may know for VRD or DARA VRD, the day 8 dosing of the PI when the CD38 goes to every other week ends up being kind of silly. And so we have other little things like the tweaks we've made. This is how I want clinical trials to look, where there's not these many inefficiencies and legacies of old days where we make progress. So very briefly, I'll talk about other drugs, and then I want to leave plenty of time for discussion. So for lenalidomide, can you lower the dose? The bottom line is absolutely. So, it's hard because all of our trials say for transplant that after transplant, you should give someone 10 milligrams and go up to 15 milligrams. That is not a sustainable strategy. It never was, never is, never will be. And the reason I say that is if you look here, this is I think, the most interesting supplemental graph from the determination study. So the determination study was a very large phase 3 study of a VRD plus transplant, versus VRD and no transplant in adults under 65 with myeloma, similar to the IFM 2009 trial of transplant in myeloma, but the IFM-9 trial only did 1 year of len maintenance. Here, they did len maintenance until progression. And you can see here, this is the average len dose for all patients over time. And you can see at the beginning, the average dose is about, close to 10. So people are starting there. You can see there's supposed to jump after 1 month. Not really. The average dose for both patients ends up being, for both arms, ends up being kind of like 11 to 12 milligrams, and it steadily goes down over time. So basically, no matter what, most patients, like if you look 3 years out, the average patient is not getting 15 milligrams of lenalidomide, not even close to getting a lower dose. Interestingly, here you can see that the patients who got transplant, the doctors apparently feel more comfortable lowering the dose a bit more. I think it's very fascinating. It had nothing to do with cytopenias. We've asked, and it has nothing to do with cytopenias. I think if someone's gotten transplant, the doctor's like, you got transplant. I'm okay lowering your lenalidomide. So it's interesting. But either way, 15 milligrams, nobody's getting 15 milligrams. In the US, I tend to use 21-day dosing, 21 or 28-day dosing, not continuous dosing. I found that to be helpful because I think that it gives patients a break and allows them to recognize what side effects they're having and not having. I think that's pretty helpful, actually. Some of my patients, the diarrhea, the fatigue, the brain fog, which is kind of the cognitive issues, they notice that they're having it better on the off weeks. And if that's happening, time to lower the dose in my mind. And then for diarrhea, I give bile acids to questions. I'm realizing, I'll mention this now, come up in the Q&A. There was an interesting paper by the Mayo Group. Dr. Gold was the first author, and I can find that, send it to all of you afterwards, because one of the arguments I get that's saying, oh, well, you shouldn't lower the lenalidomide dose for everybody because, if someone relapses at len 5 milligrams, how do you know that they wouldn't have relapsed at len 25 milligrams? And basically, there is a study, a retrospective analysis from the Mayo patients, and whether you relapse at a len dose of 5 milligrams versus 15 versus 25 has zero bearing on subsequent treatment efficacy or subsequent clinical outcomes. When the myeloma becomes lenalidomide refractory, it becomes lenalidomide refractory no matter what dose you're using. So there's no benefit to overdoing it. What about POM? So basically, yes, in my mind, POM 2 and 4 milligrams are interchangeable. And Dr. Rajkumar said the same thing. Why? There actually was a nice study here, not a randomized study, with two sequential studies of POM 2 milligram versus 4 milligram dosing. And basically, you can see here, again, I want to move quickly here, but I'll just say briefly that here, if anything, less is more, not randomized. The PFS here for the 2 milligram dosing was 6.5 months versus for the 4 milligram dosing was 3.2 months, probably because you had to hold the dose that much more for cytopenia for toxicities. So I almost always use 2 milligrams of pomalidomide, except for CNS myeloma, very rare, but in the cases where you need to get into the blood-brain barrier, POM can do it, and higher doses may be better. Very briefly, time toxicity is the last topic I'll talk about, where we leave time for questions and answers here. So it's a new concept, right? But it's very relevant. Many of you, honestly, probably more relevant for patients in India than in the US, because many patients, especially those in rural settings, are coming a very long way to get for treatment, even in a city. Like to kind of get from one side of Kolkata to the other every time I'm there is a hot mess, right? There's easily an hour plus more time of traffic and expensive and so forth. So it's a lot. So this idea of time toxicity is a toxicity that myeloma treatment entails. It basically depends for each patient, right? If someone's openly relapsing, they often have to move very quickly and they're willing to take that risk of time toxicity. But once someone's in remission, they might not want that, right? And so in terms of ways that we can lower it, this is data that I'm senior author on this. We published it last year or this year in Leukemia and Lymphoma, just ways in lymphoma and myeloma to minimize time toxicity. Just little examples here. For example, we talked about the once weekly bortezomib or carfilzomib. I still meet doctors in the US who are checking CBCs every single dose, every single day of bortezomib, and they have a holding parameter where the nurse says, okay, wait for the CBC, the complete blood count, and if the neutrophil count is not 1,000, don't give the bortezomib. There's no data for that. So I would say just skip the CBCs and just save them for day one of each cycle if someone's not having neutropenia. For patients who are getting a CD38 monoclonal antibody for any reason, their pre-medications are not necessary after the first month or two, so that's very helpful. And then in lymphoma, similar principles apply, but again, I'll spend on myeloma here. What's important here is that this is not randomized phase 3 trials. These are real world data, and like India is a powerhouse of real world data in myeloma, for example. I've seen and reviewed many of papers from many of you listening to this, and so this is a good source of real data saying like, look, like in the real world setting, we don't need to do this, and that's fine. People might say, oh, you need a randomized trial for everything. You don't. Randomized trials are expensive. They're unfair. Patient randomized trials have to collect 24-hour urines and do twice weekly bortezomib. All these reasons to say, take the patients you have and roll with it. Also, QI interventions and surveys are very helpful. So I would encourage those research because they make it out and they help to change the field. And so finally, to wrap things up, and then again, I focused high level here, but and then we'll leave time for questions thereafter. If myeloma were a house, so to speak, almost every corner could use some tidying up, so to speak, some less is more, cleaning up all the stuff that doesn't really belong to just been there for forever. Of course, everyone's care should be individualized, right? All of you know this, right? So, like, am I saying that you should never, ever, ever give twice weekly bortezomib? No, because for some reasons it is helpful for acute calf nephropathy. All of you have had patients who they get the dexamethasone and that makes them feel better afterward in terms of bone pain. Some patients do require pre-medications, etc. But I'd love to work with all of you on these ideas and more. I was joking before we started that, for example, with like cell therapy, India is showing the world how to do it, right? So like little things like that, I'm learning from all of you how to do it. You have unique challenges that, we don't even realize that we have. And so I think things like that, I think are important. We should all work together on this. So with that, I will stop. This is the quote I always take, also an Indian, also a fellow Bengali. If any of you haven't read this book, I would encourage reading it. It's called by Siddhartha Mukherjee, The Emperor of All Maladies. And it's a nice quote here about multiple myeloma, and that's what I want for all of my patients. So with that, I will stop. Thank you for your time. And again, I'm happy to use the rest of the hour here to talk about practical nuts and bolts of how I dose things, why I dose things, how you all dose things, and so forth. Thank you all again.
Thank you, Dr. Banerjee. That was an excellent presentation, and I would say a very, very thought-provoking one. In most aspects of myeloma, I think the message should be clear. We should know where to draw the line, and probably, like you rightly mentioned, less is more, and that applies for most of the drugs that we use. So, we have actually collected quite a few questions from our Indian colleagues, and can we start off with the discussion?
Mhm.
Yeah. So, starting with lenalidomide itself, many of the patients with lenalidomide develop allergic reactions, skin allergy, and some of them quite severe. How do you manage them?
It's a great question. It's hard because I wish we had more research and more trials here. So you're absolutely right. And so, our best thinking is that it's not a direct drug toxicity per se, right? It's something that lenalidomide is triggering an immune response. We know that lenalidomide can trigger more of an autoimmune phenotype, as you're alluding to. And it's that autoimmune phenomenon, probably against skin flora, is what we're probably seeing. For whatever reason, for many of my patients, it's like scalp itchiness that they notice, or rashes at different organs here and there. Again, I would emphasize that you cannot go wrong with a lower dose of lenalidomide. And so what I would say is a couple of things. Obviously, in the acute setting, discontinue lenalidomide. You can try a low dose of prednisone or daily, small or topical steroids as you can. I think the important part where I've seen people go, where I've seen this plan go wrong is if you try to re-challenge them immediately thereafter, it's not going to work because the idea, again, hand wavy, I can't prove this, is that there is this autoreactive clone of white blood cells that is being revved up by the Revlimid, so to speak, right? This is real, right? Many preclinical studies have shown that lenalidomide does potentiate immune responses. Some of you may have seen or heard or dealt with this before, or at least in the US, for patients who are solid organ transplant recipients, for example, that they've gotten a kidney transplant and they're diagnosed with myeloma. We are forbidden from giving lenalidomide for exactly that reason, because patient lenalidomide has been shown to lead to graft rejection in these patients. And so it's a big deal. So what I would say is the immune response takes time to calm down. So I typically stop it, wait for it gets better, wait a full month, and re-challenge at a lower dose. Again, just to reemphasize, and I should have put that now into future iterations as I will, that data from the Mayo Clinic, honestly, because doctors have asked me, they were like, oh, I feel really nervous. Like, you really want to put this patient down to 5 mg, only 5, they're transplant eligible? Yes, because you want them to be a sustainable, the whole point of lenalidomide, as all of you know, is to have a sustainable long-term path. So I think dose reduction is key. You don't get any points for trying to push them back to 25. But I would say there, yeah. So lowering the dose, giving them at least a month off. Technically, and I'd love to hear if any of you have tried this. I have 2 or 3 times been able to move to pomalidomide. Hard to say, it wasn't randomized, right? If I'd re-challenged them with the len, would it have worked? Who knows? But if it's kind of recurrent, I've had one patient who had like recurrent, had to go to the ER for skin itch, the emergency department, like A&E style management. For that patient, I paused and moved to pomalidomide at 2 mg, and it has not recurred.
So, this is more of a drug effect, and you don't think it's really a class effect because if formaldehyde can work, probably switching to that may be a good idea. And
I think so. And in the future, and hopefully some of these trials might be open in India, but hopefully they will. If anything, you'll figure out how to make it affordable for the world. But the cell mods, the newer version of IMiDs that are iberdomide and mezigdomide, if you look at the studies of them, as opposed to a 30-50% incidence of rash, which is what you typically see with lenalidomide, it's more like 5 to 10%. Where the hematologic toxicities are still there with cell mods, so cytopenias and needing growth factors, but the rash and fatigue is way better. So I do think that the newer drugs are less messy. If the thalidomide is the oldest, you have all those neuropathy issues, and you drop that. Lenalidomide is newer, no neuropathy, but all the skin issues. You drop that to POM, iberdomide, mezigdomide. We'll keep seeing improvement there, and I'm happy to see it.
And interestingly, many patients develop this complication sometimes months or even years after starting lenalidomide. So, in our practice, very often a low dose daily steroid, let's say
Mhm.
prednisolone of 10 milligram, or a low dose steroid with lenalidomide has helped, especially in those patients on maintenance. And due to whatever reason, we are not able to give a different drug.
Excellent. Excellent. I completely agree. Yeah, it's also my guess. I agree with you. Where it kind of comes out of the blue over time. And my guess is some change in skin flora or GI flora. It's probably some bacteria that your body's reacting to or something that there's like an autoimmune clone develops that is hard to shake once it's there.
And there is a lot of heterogeneity when it comes to lenalidomide dosing. Many people use it for 2 weeks, 14 by 21. Some use it 21 by 28. Is there a difference? What do you prefer? 2 weeks on, one
Yeah,
week,
it's a
or two
great
weeks on
question.
and 1 week
It's
off?
it's it's really annoying. So all of you know who know me know that this is gonna be my like, on my gravestone someday. This sounds morbid, but I want to be like, I'm the person who helped fix some of this because it's silly. It depends on the trial regimen. As all of you know, a lot of these myeloma regimens morphed out of lymphoma regimens, and lymphoma often does do 3 week cycles. I tend to use 21 and 28 days. In the US, we have this unique challenge, which I don't know how much success in India. I know that lenalidomide is cheaper in India than it is in the US by a huge margin. And so there's a lot of logistics that go into lenalidomide dosing in the US. You have to prove you're not pregnant, then it's an expensive special pharmacy. And so the nice thing of only having to request it once a month is just less time toxicity for the patient on the phone saying, where's my lenalidomide? Where's the drugs? Come, let me get them. So I like that. In real life, it doesn't really matter. In the maintenance setting, I do tend to use 28-day cycles, definitely 2028. The other benefit, and I see a question come out, we're going to talk about this a little bit, but as daratumumab comes to the forefront, daratumumab, isatuximab, bispecifics, all of them are every 4 week cycles. So for modern drugs, we're all doing every 4 weeks. So I prefer 4 week cycles. However, even my colleagues, not at Fred Hush, but the small centers here, some of them still use 3 week doses.
So at least as far as the maintenance is concerned, you prefer a continuous 10 milligram lenalidomide and you do not give a break in between.
I actually do. I typically do give a break. It's nice for two reasons. One, and this, you tell me if this is being silly, psychologically helpful for my patients to have a break, but also to know that a break is inbuilt. Because at least in the US, many of my patients have a dose delay and they get so nervous because for them, this is their anti-cancer pill. And if I say, look, you have a surgery plan, let me you hold the lenalidomide, hold the aspirin, and they're all like, oh no, I'm scared. I'd be like, no, you're doing it anyways. And I've had patients actually time their procedures and vaccines around that off week. But honestly, we didn't really talk about this a little bit, but for like lenalidomide associated diarrhea, not always, but sometimes that off week is helpful. And if they tell me that the way I'm feeling better on my off week, and sometimes I will even extend the off week by a week just to see. And it truly, they're like, oh yeah, when I stopped it, I did start to feel better. I know that I found my culprit and I'm able to adjust the dose, add other medications, and so forth.
Okay. So that's great. And all the trials that we look at have a standard fixed dose of lenalidomide at 25 milligram. But in our practice, we see it is almost next to impossible to continue patients on 25 milligram of len. In fact, most patients don't even tolerate 20 milligram, to be honest. So
Mhm.
do you think this is something specific to the, let's say, Indian population or the Asian population, or do you also face this challenge in your practice?
I also face that challenge. It's very unfortunate. Again, it's this theory in oncology, and all of you are well familiar with that. We used to really push for the MTD, the maximum tolerated dose, and that was it for lenalidomide. They did try higher, but the M25 was the highest. But you're right. I mean, it's not weight-based dosing, right? And so the other part of it is, I joked, I tell patients this, right? The same dose that you would give to a sumo wrestler, right, as you would to a grandmother, and that's a little silly. And so, yeah, again, I typically, like for example, for my transplant ineligible patients, anyone who's over 70, just as an example, I don't even bother with 25. I start with 15. The Maya study technically did do 25 with the Dara Lendex versus Lendex. I don't do that. I think I'd rather do 15 and push your way upwards than do 25 and lose your patient, especially because, as you know, you're starting so many drugs at that point. I don't need them to feel miserable because the zoledronic acid is also going to make them feel miserable, and the bortezomib and all this new adjustment. So if I can lower the shock of that first cycle is worth it. So I would say, yeah, starting at 15, I think is very reasonable. I don't do 20. Yeah, so I either 25. If someone's young and super healthy, maybe 25. Otherwise, I'd say 15 is a very good landing spot. If someone doesn't do transplant and they're on Dara-Lendex, I drop them down to 10 or 15 anyways. So without transplant, I try to lower down to that dose because I would argue that for the long haul, the dose of lenalidomide should not really matter whether you've gotten a transplant or not because the side effects are the same.
Do you hold Lent for patients with cytopenias? Many times on in patients on maintenance with a neutrophil count of 500, 600, but otherwise asymptomatic, not developing recurrent infections, is it preferable to continue the lenalidomide or do you need to hold? So when do you decide to hold len as far as
Yeah,
cytopenia?
it's a great question. It's complicated. You're right that I often, if it's above 500 and the patient is quite stable, I often let them ride with it if they're on 10 or 15 milligrams. Again, my first rule from the previous question still applies that I think if someone's on 25 and they're having this happen, you may well try them on 10 or 15. Again, there's never a single study that has ever shown that Len 25 outperforms Len 15. And again, that study from Dr. Goel in Blood Cancer Journal showing that when you do relapse, it doesn't matter what your Len dose is, I think is very telling. So I think a lower than 10 or 15. Below that, I agree with you. I wouldn't push it. I have some of my colleagues who sometimes try to give people GCSF, like growth factors, all the time. That has its own side effects. The only thing I would say is that if someone's always have, at least in my practice, the ones who are getting this perpetual neutropenia are also the ones who are getting the weird skin rashes, drug rashes, etc., like all low grade. So sometimes I feel a lower dose might be reasonable to consider. The very last point I'll bring up, and it's not going to be so relevant, I don't think, for the patients in India, but I heard someone say there's physicians from Iraq and everyone listening in. Duffy null status. Have you ever checked for that before, Dr. Nikhil, before? Do you know what I'm talking about?
No, no,
So
we
it's
haven't.
and I can send some information afterwards because honestly we're still learning about it ourselves, but I think it's like 15% of people of Middle Eastern heritage, of Arabic heritage have it, and it's a gene mutation where the neutrophil count is just normally low. The old term for it used to be benign ethnic neutropenia, and people have it, right? And so then you would used to be like, oh, your baseline neutrophil is 1,000. We can't give you this and that. For those patients, I would not worry about it at all. So actually, we're changing clinical trial protocol. So if someone tests positive for Duffy null, we disregard all the holding rules for neutropenia and lenalidomide. So I would say if the demographics fit, or if to your point, if the patient clearly is doing just fine. Oh, thank you. I see Dr. Helder responded. Yeah, Dan, that's exactly right. Duffy null status, Duffy associated null cytopenias. And again, those patients do not need dose reduction. The hard part is how do you figure out who they are without having to ethnically profile your patients. And there's a test that can be done. It just takes some time to get used to, but I think that would be the one consideration because in those patients I wouldn't mind at all.
That's a very interesting point. We do get a lot of patients from Middle East and African countries, but I think this is something which we have not looked at. In patients with renal dysfunction at baseline, let's say create clearance of 30 to 40, 40, 50, would you prefer starting low dose lenalidomide or would you put them on cyclophosphamide till the time the renal dysfunction resolves and then switch to len? What is your practice?
Brilliant. It's an excellent question. So, yeah, there's this joke in the field, right, that if you ask two different myeloma specialists an answer, a question, you'll get like five different answers. You'll get many different answers. I, yeah, not in the beginning. Yeah, so in the beginning, no harm, no foul to give someone Cyborg D. It's a very relevant regimen for much of the world. That is the standard regimen. Like honestly, in Australia, not even in LMICs, like in Australia, Cyborg D is their default induction regimen. They don't even use IMiDs up front. And so I think two things I would say. So one, I think if the renal function starts to improve, I think it is very reasonable to consider a very low dose of lenalidomide to try it, like 2.5 or 5 milligram. I tend to underdose it. Some of my colleagues will start at 10 or 15, and there was a study from Mayo Clinic showing that with appropriate GCSF and growth factor, you can get people to 25 milligrams, even with renal insufficiency. Again, You don't need to. You could, but my point is that actually does not improve outcomes. So I would not do that. But I think if you can get it to work, it is nice because I have had patients where 2.5 or 5 milligrams works just fine for them for the long haul. Because again, the goal here is to have a sustainable long-term solution. Because long-term CyBorD, right? Let's say someone gets CyBorD and they're not going to transplant. What's your end game? No one knows. Like I would not recommend Cy forever because that probably would put people at risk of secondary leukemia to give alkylators forever. Bortezomib forever, there's neuropathy, it's time in clinic, etc. And I want to give them some maintenance. If you can get it to work, I think it's worth it. The other nuance is that if they have, and this is a question that will come up separately, if they have renal insufficiency secondary to amyloidosis. So in those patients, I don't jump to lenalidomide. So lenalidomide is often not well tolerated in patients with cardiac amyloidosis because they can sometimes have more just heart issues or GI amyloidosis. I found that those patients get super constipated. They already are constipated with the amyloidosis. You add lenalidomide, they're super constipated. So that's problematic. Um, I'm sorry, but even for those patients, if I can get it with low dose Len, I can. Or technically, at least in the US, pomalidomide is approved for second line treatment. In the questions that you submitted earlier, someone asked, like, why don't we just use Pom up front? I would love that. I hate lenalidomide, to be very clear. Like, I detest the drug, right? I would much rather use pomalidomide for everybody. At least in the US, insurance companies won't approve it. But in the future, if someone gets CyBorD and you're moving them, at least in the US, I can argue that I'm changing them to a second line of treatment and therefore use POM maintenance. I've done that in renal insufficiency because again, pomalidomide is not renally dosed. I've done it for lenalidomide rashes. I've done it for all these scenarios. Um, there was a study by Adam Sperling, published in Blood a couple of years ago, that pomalidomide does not lead to the formation of P53 mutated myeloid cancers the way that lenalidomide does. Many of you have had these patients who get AML or ALL years after lenalidomide, and they are screwed, right? They do very poorly. POM doesn't have that problem. So I think the only downside to jumping to pomalidomide, for example, is theoretically, you're taking away that chance that, oh, if lenalidomide worked, that you stop and then try pomalidomide afterwards. We don't know that. We don't know that len to pom is any better than just pom the entire time because pom is a better drug. And so I would say that if you're in doubt, try it. The very last consideration I would say is that if any if any Indian centers have CARTITUDE-6 or the other studies that are open, many of the CAR T studies that are out there and the US label for CAR T does require len refractoriness or triple class exposure. And so the only other thing I would say, and this is a very cynical thing to say, is that if you think that your patient may qualify for something fancy in the future, it's maybe nice to give him like 1 month of lenalidomide. And if they can't tolerate it, fine. You can say you tried, you can check off that box. Again, this is very cynical of me to say, but it's come up. I've had patients who don't qualify for CAR T because the insurance company is gleefully tells me, oh, they didn't get lenalidomide. Nope, no CAR T for you. And then I have to figure it out and roll with it. So if you can get around that, I think giving just a little bit of an IMID is helpful.
So does this apply for patients of multiple myeloma with coexisting cardiac amyloidosis also? Because many of them
Yeah,
have
so in those patients, I typically
sometimes.
do not give lenalidomide. You're right. Even for transplant, when I do transplant, so transplant for amyloidosis is pretty risky. But even if you do it, I wouldn't generally recommend an IMID in those scenarios. Maybe pomalidomide only as maintenance, not as part of the induction regimen. I would argue that hopefully more novel therapies will do the trick there. People are studying other treatment combinations to help with amyloidosis in the relapse settings. I'd rather do that just because, again, most patients with amyloid, technically speaking, they're diagnosed before the cells are cancerous. And so if you give them CyBorD or Dara-CyBorD, it works and the cancer and the amyloid never comes back. And so I'm okay with that. So I'd rather not overdo it for those patients.
Right. And patient on bortezomib as well as lenalidomide developing diarrhea. Any clinical clues to know which is the drug which is responsible, bortezomib
Yeah.
and lenalidomide? Because what is post-bortezomib diarrhea is a very common thing, and many times we give them Imodium and other medicines, and it is well managed. But sometimes it can be because of len also. So how do you look at this?
Yeah, so it's a great question. No great way of saying. And so I'll answer that. And then I also see a question in the chat that Dr. Sumit asked about pneumonia. So the same principle. Obviously, in real life, very hard to tell what is what. Technically, diarrhea, you're right, I associate more with the lenalidomide, and pneumonia is more with the DARA, and neuropathy with the bortezomib. In real life, could be a little mix of everything. I will say that if I'm ever in doubt, again, for lenalidomide associated diarrhea. Bile acid sequestration can be quite helpful, right? The idea is that it's leading to this mismatch of bile acids and they coming out into the stool and they're causing weird bacterial reactions and that's causing it. And so cholesevolum or cholestypol or whatever exists in India, it's kind of annoying. At least in the US, it's dosed like 4 times per day with every meal, but it works. And I have had patients, and there's actually was a randomized study published last year, small, but showing that it does actually work. And so I would say if you try that therapeutically, and the diarrhea vanishes, you have your answer.
Right. So I think that's a great clinical way to look at it. In patients on lenalidomide, especially maintenance, most of them are on indefinite maintenance, at least at our center. So do you
Absolutely.
think definite versus indefinite maintenance, there is a significantly increased risk of second primary malignancies? So do you
Is
cap
it
len maintenance at 2 years or do you give it indefinitely?
excellent question. So I tend to offer it indefinitely, with the exception of MRD negativity. And that'll be a whole other talk someday about whether how relevant that is or isn't. I would say that there was the BMT-CTN 0702, the stamina study was a large US study that showed that not randomized, but they changed the protocol. More than 3 years of lenalidomide appeared to outperform less than 3 years of lenalidomide. There, in terms of PFS, the SPM, the second primary malignancy risk was the same between them, small, hard to say. All those patients got transplanted, and so it's really hard to say what is a transplant, what is lenalidomide. There's a lot of unanswered questions there. So I would argue that even if someone's gotten Len for more than 1 year, they probably are at risk of these second malignancies. And the other part, I tell patients about this, right? Because with CAR T, the same principle applies. That you only can get a second cancer if you're alive, right? If you're dead, you don't get it. And so, because lenalidomide has been shown to improve overall survival, you have that immortal time bias. That patient who lives long enough to get a second skin cancer, by definition, is alive to get it because the myeloma didn't kill them. And so, it's a nuanced discussion. I've never had a patient say no. Even in the US, even at recently 10 years ago, we were often avoiding lenalidomide maintenance in patients with a history of breast cancer or lung cancer or other cancer. I would not do that. Unless the patient's looking you in the face and has MDS, myelodysplastic syndrome, I would not recommend withholding the lenalidomide just because it has a survival benefit. And I think it's unfair to not give patients that chance just because they have a history of breast cancer 20 years ago, for example.
And again, I think this question is also from Dr. Sumit. A great question again. This is something which we wonder very often. For a transplant ineligible myeloma patient who has achieved a deep response, let's say after 6 cycles of VRD, they achieve an MRD negativity. What is the optimum number of cycles to be given before we can switch to maintenance? Is it really mandatory to give 8 to 10 or 10 to 12 cycles if patient has already achieved an MRD negativity after 6 cycles?
So the short answer is no. Yeah, so I think it's a great question. I typically say 6 to 9 months. The hard part with cycles, right, is that cycle, depending on who you ask, cycles are 3 weeks to one person, 4 weeks to one person. The IMRA study used 6 week cycles. So it's just like, this is crazy. Nothing makes sense. So I would say 6 to 9 months, considering my sweet spot or a response plateau. I think it's very reasonable to move them to maintenance. Again, why 6 to 9 months? That study I mentioned, the Laroca study about dropping the dex after 9 months seemed to make a difference. And so I think that is a great plan to aim no later than 9 months. If they've achieved the CR MRD negativity, I think that's a great plan.
Great. And patients
Perfect.
on lenalidomide as well as pomalidomide, what is your take on thromboprophylaxis? Do you use aspirin? Do you use LMWH? And what are the factors you take into consideration while deciding this?
Absolutely. And I will say, Dr. Nicholas, I might have to go after this question because it's 6 a.m. here and my toddler just woke up and I hear him banging at the door.
Oh,
So I'll
okay.
do it around two later. So I would say that for in general, I think aspirin is more than sufficient for most patients unless they have a high history of VTE risk. I don't use the SAVES or IMPEDE or PRISM calculator. I just don't know what to do with them. In my mind, the only exception would be if you're ever are combining carfilzomib with an IMID, you should be using either low molecular weight heparin or a DOAC, a direct anticoagulant like a Pixaban or a Doxaban, etc. The idea being in the Sloan Kettering data, and this is Dr. Neha Korde, she published these data. They found that if you just do aspirin prophylaxis with VRD alone, probably about a 4 to 5% risk of VTE. With KRD, probably closer to a 15% risk with aspirin alone. So I think you do need to use something stronger in that regard.
Right. So I think we'll wind up after this last question. Probably the
Yeah.
other questions we have collected, I can always mail it to you. For
Yes,
patients
please.
with deletion 17p extramedullary disease, do you think pomalidomide is a much better drug compared to len upfront?
It's a great question. The short answer, we don't really know. I suspect it is, to be honest, because you can stay on a drug for longer with fewer dose toxicities and fewer risk of 17B deletions elsewhere. However, I think the challenging part is we don't know. I think for EMD, I think POM does have better blood-brain penetration. This is an example. So I do think that for EMD, that one I can answer. Because for CNS myeloma, we do give POM over LEN, and it does work. Not forever, but it does work. For 17p, the jury's still out. I think for 17, the key part for 17p, we think, is not the depth of response, it's the durability of the response that's the tricky part. And so if you keep people on for a longer time, that's what probably does the most difference. And so that's a scenario where maybe POM is just better tolerated than LEN, and that might be my suggestion to try it, but it's hard to say.
Okay, I think thank you, Dr. Rahul, for joining us. It was great having this discussion with you. Again, a lot more unanswered questions, which we can probably mail it to you and have a discussion sometime later. But I think these are the discussions that we should have because many of these data are scarce, and people who see myeloma patients day in and day out, these clinical vignettes would go a long way in helping us treat our myeloma patients better and hopefully with less toxic therapies. So
Absolutely.
thank you once again for joining us today. And I would thank the audience from everywhere who has logged in through the delegate link as well as the faculty link and pouring in all these questions on today's webinar. So
Thank
thank you so
you.
much once again.
Thank you, Dr. Nicola. Thank you, Dr. Bhagava. Thank you all for listening. I'll see you all either at ASH or at the SAT Symposium in Mumbai or somewhere else thereafter. Have a wonderful evening, everyone. Thanks again.
Thank you. And I also thank MQR for providing this platform for conducting this webinar. Again, it was very smooth and there were no hiccups in between. Thank you once again. Have a great weekend.
Thank you all. Yep. Bye-bye.
Recording stopped.